standard nursing terminology. Let's give him a big welcome.
Thank you. Okay. Thanks. Hello, everyone, dear experts. I'm Yang Lei from China, Henan Hongliu Hospital. This is my great honor to attend this conference, and I'm so glad to meet all experts and friends. We can exchange the experience in the development of nursing informatics. This is the topic I talk about. And why do we development? Yes, okay. Why do we develop this intelligent nursing information system? We have entered the age of AI, which will have a profound impact on the development of the entire society and various industries. How nursing can embrace artificial intelligence to aid development nursing that is worth exploring and researching. And AI nursing products and use in the nursing care are becoming more and more extensive. And AI nursing also have a great potential. The development of AI of nursing informatics also face many challenges and opportunities. How to solve nursing big data, the promotion and application of nursing terminology, and the development of nursing decision support system, and the development of nursing robots and wearable products, and the application of large language models in nursing, and so on. So in China, national policies are also promoting the construction and development of smart hospital and smart nursing. But at now, the application stage of nursing information system has some gaps and problems. For example, nursing information system is a functional system lacking standard nursing procedure, and the standard nursing lacking standard nursing process, lacking support from evidence base, no designing making support function, no nursing terminology. So it is slow. So based on the above, we decided to design and develop the intelligent nursing information system that truly fits the condition of nursing and can keep up with the development of the times, and it can also solve the problems of the current information system. We designed and developed the CCC fully intelligent nursing information system. The basis of reading intelligent is to have the standard and structured nursing data, which require use nursing terminology in clinical nursing. So developing an evidence-based nursing knowledge base based on nursing terminology is the key to releasing for CCC smart system. Our CCC nursing knowledge base research and application teams were founded 2016 and led by Zhong Wei Institute of Nursing Information. The team members include evidence-based nursing experts, specialist nurses, statisticians, and medical and nursing informatics professionals. We translate the Chinese version of CCC terminology and organize the development of the CCC clinical nursing knowledge base, and including nursing information software companies such as Shanghai Zhongyun Information Technology Company and Man Hospital and other hospitals in China. That is also a team of experts consults from the National Nursing Center. The CCC clinical nursing knowledge base includes the nursing assessment knowledge base, which follows the CCC framework structure standard and contains all nursing risk factors, symptoms, and signs related to nursing diagnosis, and patient information, past medical history, current medical history, and other assessment items. This is the CCC output. And the nursing knowledge base maybe have more than 100 nursing risk score, and we implanted into the nursing assessment knowledge base, like this. And the nursing diagnosis knowledge base is the CCC diagnosis, maybe have the 76 nursing diagnosis. And the knowledge base have the nursing interventions. The nursing interventions knowledge base developed evidence-based nursing interventions for nursing diagnosis. It has more than 1,800 nursing interventions, including for various specialties such as internal medicine, surgery, obstetrics, and gynecology, and pediatrics.
Question session.
What? Okay. What?
5 minutes left.
Okay. And comply with the CCC structure standards. And this is the intervention knowledge base. Sorry. We organized the ESRPGIO intelligent logit model in order to realize the development of the CCC smart system. This is my work team and the photos of work. And the CCC system, smart system is online, the timeline. So this is the CCC smart system. This is the login, the face. And this is the patient list. The patient list. And this is, sorry. And this is the menu. This is the photos for nursing caring for patients. Use the CCC smart system. This is the main system with the vital signs trend chart. And maybe have the holistic nursing assessment include physical, and the past medical history assessment, and as well as special assessment content. This is a specialist nursing assessment. And after the nurse completes the overall nursing assessment of the patient's nursing risk score and the nursing diagnosis will be the intelligent, recommended, and exported. For example, this is the pediatrics will then drive some risk scores for children. This is the nursing diagnosis list. And nurse select the patient's most important nursing diagnosis and corresponding nursing interventions for the selected nursing diagnosis will also be intelligently accommodated. We have the bundle care for nursing risks. This is a whole nursing plan. Maybe have the medical order, interventions, and nursing bundle care. This is skin care. The skin care maybe have the standards, the assessment and the record content to promote hemorrhagic care by nurses. And this is the nursing outcomes. So we have the whole nursing process, the nursing big data. The application effect of the CCC Smart Information System. One, we have the clinical application of standard nursing process, nursing evidence-based practice, and bridging the gap between evidence and clinical care. We have the structured code nursing data for all patients. I think it's very helpful for the student nurse and the young nurse. And we also promoted the 3 University of Nursing School to open new course in nursing informatics. And we hold an academic exchange meeting on topic related to nursing informatics and smart nursing development every year. Yes. This is in the University School of Nursing. So we can organize the nursing data of all patients, such as the distribution of nursing diagnosis, distribution of nursing intervention, and the nursing risks. So in a review article paper of the global nursing terminology in 2017, application the nursing terminology, there was no nursing terminology application in China, but now we have filled this gap. And we surveyed nurses in our hospital on the application of the CCC smart system, and the nurses give positive feedback, like this, and this. So our team did several small studies and published the articles. So the promotion and application of CCC Smart System has been used by near 12 hospitals in China and has achieved phased promising results. And there are 36,000 hospitals in China, and there is still a lot of room and prospects for the promotion of CCC, Intelligent Nursing Information System. In future, we will continue to update the nursing knowledge base with the CCC to make the system more intelligent. We will also continue to promote the application of CCC in other hospitals. So this is the end of my speech. Thanks for your listening. And last, let's remember Dr. Saba. Thank you. Welcome China. Welcome to China.
Are there any questions for Yang Lei?
Hopefully the mic will work.
I've noticed that in your presentation you put the Chinese medicine in the system as well. So what I'm trying to say is that 就是你在你的系统里面放了中医，对不对？ So people who may not know, so in his presentation, he actually put the Chinese system, the Chinese medicine system, combined with the Western medicine together in one system. So what I'm curious is about how do you combine, how do you balance these two different systems? 就是我想问的是，因为你的系统里放了中医和西医嘛，
没有中医，
然后如果你怎么样？
没有中医。
你刚刚不是有一个中医的那个诊断的吗？
那个不是中医的诊断，那个就是一个这个 CCC 的那个就是CCC 的那个诊断，它不是中医诊断。It's not a Chinese medical. It's a CCC nursing diagnosis.
Okay.
Yeah.
See, thank you.
Thank you. Any other questions? We have time for one more.
So Lee, you said that right now the intelligent CCC system is in 12 hospitals, and there's 3,600 hospitals to go. Do you think you will do it by hospital system, one system at a time, or how do you hope to increase the adoption? Does that make sense?
一鸣，帮你翻译一下。You mean the system is used how many hospitals?
You said there's many hospitals.
It's many 20 hospitals.
In 20 hospitals.
Yeah.
And I guess I'm asking, do you do it by hospital system? So one hospital system has many hospitals, you do it by system, or you do individual hospitals?
One at a time or many at a time?
Many times.
Many at a time?
Yeah.
It's okay.
You're
I
in.
just want to know if you have like
We have the two technology company have the CCC system, and in my hospital with cooperation with the company, maybe we own the CCC system, maybe use 10 hospital.
okay.
Yeah.
Okay.
My hospital have 1,000 beds. Yeah, 1,000. Yeah, 1,000.
Great. Thank you very much.
Okay, thank you. Thank you.
So thank you. It gives me great pleasure to introduce our next speaker, Professor Ernesto Moraes from the Nursing School of Porto. He's going to give us a presentation on the cross-mapping the Portuguese nursing ontology with ICMP, SNOMED CT and NANDA I. Thank you.
Thank you. I don't know if it is. Yeah, it is. Can you hear me well? Yeah? Okay. Thank you. Good morning, everyone. Thank you to the Scientific Committee of NY 2024 for accepting this presentation. Like said, I'm Ernesto Moraes. I'm a nurse and I'm also associate professor at Porto Nursing School, where I am also the director of the ICN Accredited Center for Information Systems and ICNP Research and Development. Thank you. First of all, I'm here representing the first author of this work. For personal reasons, Professor Fernando Oliveira was not able to be here with us, but we both work in the same center and in the same team. So I'm really glad to present this work that we are doing. Yeah?
It was hard to hear you.
Oh, I'll speak louder. Okay. We both work at this nursing school in Porto. There is a town in the north of Portugal, very well known for its port wine. Portuguese nursing has a path of more than 25 years in the area of nursing information systems development. And here you will see some milestones related to this evolution. In 1996, as a result of a master thesis with the name Nursing Records, Scripto Tradition to an Informal Discourse, and this was by Abel Paiva, a protocol was celebrated with the Ministry of Health, establishing what was the first informatic documentation system for nurses in Portugal. And this was implemented in the great majority of public hospitals and health centers with ICNP, that is International Classification for Nursing Practice, on its back end. This work led to the first PhD thesis in nursing in Portugal, also by Professor Abel Paiva. After this, about 2005, Paulino Souza, also a colleague of our school, created the nursing information sharing system between hospitals and health centers in real time. As a result of all these works that were performed, in 2007, the National Nurses Association established that this system should be used and ICNP should be used in all systems that will be developed from that time on in Portugal. And at the same time, Filipe Pereira, also a colleague from our school and our center, produced the first Portuguese minimum data set in our country. Of course, with all this data that we gathered since 2005 until 2012, at this time, by request of the Ministry of Health, we carried out a content analysis of the existing documentation in the nursing information system from 92 hospitals and more than 300 health centers. And based on this analysis, we proposed a unique national customization to be used in the public nursing information system. However, this customization was not enough to represent nursing knowledge as we wanted it to be represented, and that is why we began the work of development of a nursing ontology. This work moved on until 2019, and that is where the Nursing Ontos project, as we call it, started a nursing domain ontology, and this has been developed by our center with the collaboration of orders of nurses in Portugal. And this is to represent the disciplinary nurses' knowledge in health information systems, incorporating nursing terminologies, ICNP, of course, and now also SNOMED CT. At this moment, the Portuguese nurses order releases the nursing ontology, the newest version from 2023, to the software development vendors. to be used in the back end of their own health systems in Portugal, free of charge. In practice, an ontology is a data model, is a clinical data model that represents a set of concepts within a domain as well as their relationships, and this is the main strength of an ontology. In the case of nursing, this is a new approach in health informatics. It is a set of clinical nursing data models and their relations, and we are talking about assessing and evaluating items, nursing diagnosis, objectives, interventions, and outcomes. I would like to remind you that the ontology is not the system itself that nurses use at the bedside. It is behind the system. It is in the back end of any software that might be developed. This is an example of our ontology browser in Portuguese and in English. It is translated now to more 7 languages. And this, like I said, this ontology is available to all Portuguese nurses through the use of a browser that is available on the website of the Order of Nurses. The latest version of this ontology has more than 6,600 expressions, of which almost 1,500 are assessment or evolution items. More than 1,000 are nursing diagnoses, more than 600 are nursing objectives, and almost 3,500 items are nursing interventions, of which around half of them are related to evaluation items. The purpose of this current work was to define a set of correspondences between the items of the Portuguese ontology and the ones from the terminology ICNP, SNOMED-CT, and NANDA International, which have the same or similar meaning. In this process, we used the TR 12300 ISO standard of 2016 on the principles of mapping between terminological systems. The first one being the cardinality principle that verifies the candidate target term from the terminologies that represent the source term from the nursing ontology. The second one being the principle of equivalence that verifies semantic correspondence. First, by meaning equivalence, lexical or conceptual, and this is considered the most robust level of equivalence. Second, by conceptual equivalence, usually based on synonyms, and this is admitted to terminologies. And this is considered the second highest and robust level of equivalence. The third option would be the absence of equivalence. And this process allows us, with the ontology, the alignment with the global health digitalization strategy, enabling high levels, we hope, high levels of interoperability. Some examples to demonstrate the work performance, and we will use some mapping examples. In the first one, we have here the nursing diagnosis impaired airway clearance, and it appears that it is possible to map it with the 3 terminologies. In the second example, we have the nursing diagnosis readiness of caregiver to enhance ability in performing inhalation therapy. And this expression can be fully mapped, but only with more than one term from ICNP and SNOMED-CT. When mapping with NANDA International, it was not possible to find single terms that could map with our ontology. In this intervention item, it is instructing parent about applying mechanical insufflation exsufflation device. It is clear that it is possible to map it with SNOMED-CT. But with ICNP, part of the expression is missing. That is mechanical insufflation, exsufflation device. Mapping with NANDA International doesn't apply in this case, of course. Now, the example of a domain that is very frequent and relevant in nursing records, that is the airway clearance. Airway clearance in the nursing ontology is a set of clinical terms incorporating entities that are represented in this ontology by 139 statements. of which 34 are assessing items, 24 nursing diagnoses, 5 objectives, and 76 interventions. When mapping the assessment items with SNOMED CT, more than 94% of the items are fully mapped, and only only in 2 expressions a term is missing. We didn't perform yet the mapping with ICNP because ICNP is targeted to nursing diagnosis, nursing interventions, and nursing outcomes, and with NANDA International it's not applicable here. Regarding nursing diagnosis, most of the terms are mapped with ICNP and SNOMED CT. All expressions of the Portuguese ontology map with SNOMED CT. In the opposite, only one expression of nursing ontos maps with NANDA International. When considering nursing objectives, we can map the 4 objectives of nursing ontology with both ICNP and SNOMED CT using semantic blocks, while one objective lacks a term to obtain the complete mapping. NANDA International is not applicable, of course. And finally, regarding nursing interventions, again, NANDA International is not applicable here. When we map nursing ontology with ICNP in 12 interventions, it is missing at least one term, while with SNOMED CT the mapping is complete. Now to the conclusions. When analyzing the entire nursing ontology, we may conclude that SNOMED CT provides the most comprehensive mapping process. Regarding NANDA International, and I'm talking about in this specific case, we mapped only one concept from the nursing ontology, impaired airway clearance maps with ineffective airway clearance. Some nursing core concepts, and this is very concerning to us, such as the adaptation or readaptation facing a life event that are documented by nurses at bedside or at patient's home, are among the least mapped domains. And this requires, of course, a significant effort for the development in broader terminologies. They are not represented in broader terminologies. And finally, thank you. And finally, most statements in the nursing ontology are fully mapped with ICNP and SNOMED CT. We are talking about more than 80% of the terms, ensuring a high level of interoperability in electronic health records in Portugal as well and as internationally. On behalf of my team, thank you very much for your attention.
Do we have any questions for Professor Moresh?
Hi, thank you very much for this interesting talk. I was wondering, did you do the mappings just like to see how well the coverage was of nursing onto, or are you also planning on using the mappings? So
Sorry, I quite didn't understand.
Is it working? Yes. Ah, yeah. Oh, yeah. So I was wondering, did you just do the mapping to see how well the coverage was, or are you also planning on using the mappings now? And like,
well, we don't have another option. If we want to build systems that talk with each other, we have to perform this mapping. We have to perform the semantic mapping with other terminologies, and we have to perform the technical mapping using the standards from ISO, of course. So we had to do it to be compliant with for instance, the European Union strategy of interoperability of systems. Yeah.
Oh, thank you.
Thank you.
Thank you. Good question. Any other questions?
Can I ask you a question?
Yeah.
I wonder, how was it to politically get the approval at the national level to have a one on ontology used across the country?
We have been, sorry, we have been working with the National Nurses Association, that is the Order of Nurses, since the beginning of this process. And in the first part of this process, that was when we built the national system, it was built by the Ministry of Health, the Portuguese Ministry of Health. In Portugal, the majority of hospitals and health centers are public hospitals and health centers. So when we gathered these three entities, us, the Ministry of Health, and the Order of Nurses, we kept going with this work, and now it was easier to influence the possibility of incorporating the nursing ontology also.
Thank you.
Let's see what happens. Thank you.
Thank you. Sorry.
Okay.
Thank you for an excellent presentation. I would like now to introduce Dr. Leanne Curry from the University of British Columbia. She's going to be presenting to us integrity, justice, equity, diversity, inclusion, and indigeneity of, into an informatics curriculum.
Thank you. Sorry. No worries. Good morning, everybody. And I am we've recently created an informatics curriculum at our school, and because of that, we had a nice opportunity to take some of these ideas of equity and justice and integrating them into our curriculum. So our program that we've created is a graduate certificate in clinical informatics. It's freshly minted. We just deployed it last fall, and we actually just finished teaching the last course of 3 courses last Wednesday. So we're hot off the press. The idea of this program is to have courses for clinicians to learn how to become clinical informatics specialists, and we structured it using some principles of adult learning. We're expecting people to be, adult learners want to see something that's useful for them that they can apply in the real world, and so we really tried to be less talking head, and instead our classes happen every 1 day a week for 2 hours face-to-face. There's a pre-recorded lecture that students watch beforehand. They have readings to do. They come in and discuss the readings. We also have largely team-based assignments, and this cultivates the professional team type of work that clinical informatics specialists will do in their work. We also wanted to take this whole person perspective, where we're thinking of the person brings a lot of experience with them to whatever course they're doing as an adult who's already a clinician in some specialty. And we wanted that to be centered where each person's perspective can be valued and shared across all of the other students in the cohort. We went to one of the things as we were planning the curriculum, which was about, 15 years, but really hands-on for about 2 years in planning, was we wanted to integrate equity, diversity, inclusion, and indigeneity. We come from Canada, where we have a history of colonizers coming in and colonizing our country, and many other in the room will have that experience. In Canada, the context is a bit unique. We have a number of different treaties that are in place, but we also have a number of different lands that have not received any sort of a treaty. So in that context, at my university, we are practicing on what we call the unceded territories of the traditional peoples of the region. So we are trying to really advance the reconciliation to redress historical injustices that have occurred to Indigenous people in Canada. So because of these initiatives that are happening, we had a lot of opportunity to draw on resources that were centering the vision of equity, diversity, inclusion, and indigeneity. We're focusing on the Truth and Reconciliation Commission in Canada, which was something that's about 10 years old now, and there are 63 calls to justice for redressing historical injustices against Indigenous peoples. We also were taking up some of the Black Lives Matter and anti-racism initiatives that were happening around the world at the time. We also had a big focus on gender equity. So, and then lastly, kind of focusing on ableism. So especially in the context of developing technologies, we really fret that we're developing things that are exclusive and have an ableist perspective. So we want to address that information. So our curriculum approach I mentioned is team-based. We have a number of professional presentations that students either do on their own or in groups. And as I mentioned, we have a lot of professional discussions that the faculty facilitate. One of the main assignments that we do is called Journal Club. And in this assignment, it's a team-based assignment. Each of the 3 courses, the students are put on a team and they're assigned a reading, or they can pick which reading they want, but there'll be 5 or 6 of these or 10 of them, depending on how many students are in the program. And we pick the topic. We found that in doing this type of assignment in other classes, asking the students to pick their own article was often too difficult because they didn't know anything about the topic area. So we just decided that we would pick the topics that were relevant to the course content, but the students were able to do the critical analysis of these articles. We framed it around the Joanna Briggs Institute critical appraisal tools. So that's kind of your traditional evidence-based practice assessment type activity. But since this group was clinicians, we knew that they didn't necessarily know a lot about technology. So we created a technology critical appraisal tool that was very focused on more about did the technology make sense to you as a clinician? And then lastly, we created a thing we're calling an authentic resource evaluation tool. And this was our way of integrating equity and diversity, inclusion and indigeneity into the content. In making that authentic resource evaluation tool, we focused it on this idea of, I'm not sure if any of you have seen this model that's out there. It's, the idea here is that the vision would be to become anti-racist, and I would say becoming equitable. But through that process, people need to ask themselves questions and know which zone they're in. So if you're in this fear zone, you might say, I deny that racism is a problem. Or you might say, I avoid hard questions. I strive to be comfortable. I talk to others who look and think like me. In the learning zone, we have the idea where, I'm just not going to read all of these, but a question someone might ask or be able to say, I understand my own privilege in ignoring racism. And then in the growth zone, the idea of I educate my peers how racism harms our profession. I sit with my discomfort. So this is what we do at the very beginning of this entire program is say, okay, we don't ask people to disclose where they're sitting on this model, but we ask them to think about, is this the perspective that you're bringing to thinking about your work as a clinician and your future work as an informatics specialist? So towards that vision, we adopted a model from an Indigenous pedagogy book, and we ask people to, for each of the articles that will be, could be standardly assessed through the Joanna Briggs critical appraisal tools, we also ask them to address authenticity, representation, and illustrations where applicable. And we tried to generalize this across all of the different aspects of ableism, inclusion, and anti-racism. We also built on, we had a couple of tools that were existing at our university, a strategic an equity and anti-racism framework, as well as an Indigenous strategic plan. This is the technology critical appraisal tool that we created, and it was based on, sorry, I don't have the name right in front of me, it was a publication looking at critical appraisal of technology articles. So the article would be appraised through standard evidence-based practice tools, through this critical appraisal tool for technology, and just as part of the appraisal was including the EDII components. The next assignment that, one of the other assignments we created, we have the students in the human-computer interaction class do a cognitive walkthrough where they do an assessment of a website or a software that's a health-related software, and have them critically evaluate if the website meets all of the heuristic evaluation capability or components that we'd be interested in. The students in the course, first of all, create a persona, and we ask them to consider what aspects of this person might be addressing equity, diversity, and inclusion. In this particular course, we were using a software called Get Checked Online. It's a website that our Centers for Disease Control in our province of British Columbia use for people to do a self-assessment and order their own test for sexually transmitted infections. And we, I see our team in the back here who helped us create questions for evaluating EDII using while someone's going through a cognitive walkthrough. And so again, we tried to integrate these things in such a way that we would just be making it a normal part of the assessment that is not normally included in the activities. The third assignment that has an EDII component to it was the annotated bibliography. The students select a topic and they do a critical evaluation of a theme with 10 articles in it. In this, they would use the Joanna Briggs tool and the Authentic Resource Evaluation tool. Again, just this is the normal part of the assignment and including it as part of all of the activities where relevant in the class. So in debriefing the students last week, how did you like having the EDII resources included in the course? One person said, "The focus has been so important. It's surprising that most of the articles that we looked at did not have any EDII in them. It wasn't even mentioned." Another person who actually, during the 11 months of our program, got a job as a clinical informatics specialist even before she was finished the program. She said, I'm actually using the heuristic evaluation tool to support a new project on perinatal nursing documentation. So I was like, really? And I got very happy and kind of verklempt, because to me, this was like translating teaching right into practice, and it just made me so excited. We also had a person disclose. She said, I know I'm supposed to get this, I'm supposed to do this, but I still don't get this. And one of the other students in the class said, let me help you understand it through my experience. So the person who made this statement, she said, I know I'm a 50-year-old white lady, I just don't get it. The person who said, let me tell you about my experience, is a Chinese-appearing woman who went on to disclose that her husband was white and that she had spent 25 years trying to educate him about the experience, because their children will be treated as Chinese and not as white. So this, to me, was quite an interesting experience. This is after 11 months of a cohort being in a classroom every Wednesday morning for 11 months. And they could have this conversation. The first thing, this person felt safe enough to say that she didn't get it, and this person felt safe enough to say, let me teach you, my friend. So in conclusion, we are making EDII as a normal part of assignments has got the potential to transform practice and achieve the goals of equitable healthcare delivery. Professionals need the foundational knowledge and a safe space to engage in this transformation. And I'll close with saying we can do better. Thank you. Any questions?
Thank you. I think EDII has always been in the fabric of nursing, but we don't always characterize it or address it with a formal name. So I love that you integrated this into your program. I love that you addressed creating a safe space. Can you share some tips in terms of creating a safe space so that people feel comfortable? Because it took about 11 months to engage into this level of conversation, but I'd love some tips.
Yeah, and I do think, since it was our first iteration of the course, we had a lot of lessons learned. I think that I call it the bubble, the concentric bubble picture, that was really hard at the beginning. A lot of people kind of choked, and so I would approach it a little bit differently in the next cohort, where we could probably spend a little bit more time doing some sort of self-reflection activities. Yeah, we haven't quite figured out exactly what that's going to look like next time, but I do think people who are not ready to, or who are not going to be taking this up as an active part of their world, they're everywhere, right? And whatever perspective you're trying to get someone to think about as to change towards, it does require safety and making sure that there is no judgment passed when someone maybe makes something that might be considered a misstep. And that truly is what we try to cultivate in our, and do this while we're teaching. So I'm going to have to think about that some more, because we do it in the moment, and we work really hard to have enough space for conversation. One of the other things, because of the structure of the course and it being largely discussion-based when we meet for 2 hours a week, it allows space for people to reflect and then perhaps make a comment. Thank you. Uh-oh.
While she's walking up the stairs, I just wanted to ask, have you looked at the Harvard bias questionnaires?
No, I haven't.
We use them with our Junior 1 students.
Oh, great.
They can do them in private,
Okay,
and they learn about themselves,
Excellent.
about their hidden biases that they may not be aware of.
great, excellent, thank you. Taking notes. Good. I think there's time for one more question.
Can you hear me? Yeah?
Yes,
Yeah.
yeah, I can hear you.
It's more of an observation, really, than a thank you, because it's something that's come up, and I think if we embed the EDI requirements at the beginning for people, because within our technology platforms, I don't think it's always really considered, and I would be suggesting that it's actually now becoming more apparent that we need to have that as part of our technology checks when we're implementing documentation, when we're implementing new skin assessment tools is a prime example. It's a piece of work that we've just done and worked with one of our university partners about the evidence base and what we need to be incorporating. So, you know, big shout out to you for embedding that into our programs.
Yeah, thank you so much. Oh, Nicola has a question down here.
I just want to echo huge thanks for this really, really important subject. I think everyone is struggling how to get this right. You talked about your course having space and safety. What would your advice be, though? Because what I'm seeing on a very practical way in the UK, a lot of this really important discussion is being taken out on one of the other digital platforms, and that's Twitter and X, which sadly, I think, creates often hate on all levels to all people, and quite a complicated and challenging subject is being played out on Twitter, formerly X. And I, as a very senior nurse leader in the UK, am incredibly worried about the division that is creating, not in a safe space, but behind closed doors.
Yeah, no, that's a great point. And, you know, that makes me think we need some component of that in our curriculum. I do think this is a challenge all over the world. I'll disclose I'm Indigenous heritage as well as settler heritage in Canada. So I'm a quarter Métis Cree, and I've been on a number of Indigenous committees across the university for 15 years. And it's very challenging because I'm white passing. People will say lots of different things in front of me when they don't realize that I'm actually identify as Indigenous and have a grandmother who was in a Indian residential industrial school, which is, you know, I think you can't change everybody, but you can start the conversation. You can have people reflect, and I'm going to definitely look at those tools. But the concentric bubble is a really good place to start because it allows the conversation to start. And a lot of my work over the last 15 years with talking about Indigenous sensitive topics has really ended up being one-on-one. And we do have some good recommendations for someone and how to be an ally. So, and we actually, in our curriculum across the health sciences at my university, we actually have a course on allyship. If you're not an Indigenous person, here are some tools for you to learn how to be an ally. So I think we could do that better and translate that into all of the othering things that we do around ableism or any other, I was going to say disabilities, but I got called out on that a while ago saying a disability isn't necessarily a problem. So we need to be thinking about it differently. But I do think we have to learn some of these things. Thank you. Thank you.
Thank you for a really inspiring presentation there. Next, I'd like to welcome to the stage Robin Lynn Dyer, who's a clinical IT facilitator at the University Hospitals of Leicester NHS Trust. He's going to be presenting on digital documentation in healthcare, empowering nurses and patients for optimal care. Thank you.
Good morning, everyone. We are excited to share the insights of our project that we've been long working in our local trust at University Hospitals Leicester. And we wanted focusing on enhancing the digital documentation practices within our trust. This closely aligns to the broader objectives of the digital transformation vision of NHS England. I am Robilyn Tritidia, an internationally recruited nurse from the Philippines, has practiced nursing in the UK, and one of the participants of the Chief Nurse Fellows Cohort 3 of our trust. I'm joined together with my mentor.
Thank you. Thanks, Bobby. My name is Antonella Ghezzi. I'm Assistant Chief Nurse for Research and Innovation at University Hospital Leicester, and I'm so proud to have Tweety here with me. It's her project, and she worked very, very hard to be here today with all of you. Thank you.
In the context of the NHS ongoing digital transformation vision, we wanted addressing a critical aspect of the healthcare delivery, the efficiency and effectiveness of nursing documentation. The NHS England just published its guidance towards a unified vision of nursing and midwifery documentation.
Very, very few words, because I don't want to take much of your time. But I wanted to mention that Tweety has joined the Chief Nurse Fellowship Program. We are on cohort 4 this year, and she has excelled, hence our participations, your participation here today. And the Chief Nurse Fellowship Program is a 12-month program that some of you might be interested in. So we're here at the end of the session to take questions and over lunch as well. We release nurses once a week for 12 months. So if you are interested in knowing more about how we do that from a financial perspective and also from a practical perspective, please come back to us and we will inform you on that. And what I would like to say is that Tweety, 12 months ago, she was a junior IT facilitator, and now she's a senior IT facilitator and also a senior Chief Nurse Fellow.
So the project was grounded in a theory of a professor at Florida University. We wanted to see the intersection of digital proficiency, nursing excellence, and patient-centric care. We've integrated various frameworks in this project, and I facilitated a structured brainstorming together with the key stakeholders of the project.
So the project itself was one of the requirements for the Chief Nurse Fellowship to touch on the pathway to excellence, which very gladly we have achieved in one of the sites, and we're applying on the second site as well in Leicester now. But Tweety, with that project, has touched on every single arena that you can see up there, starting from shared decision-making, safety, quality, leadership, professional development, and well-being. Well-being not only for staff, but well-being for patients as well through digital technology, advances in digital healthcare.
We've also incorporated the What Good Looks Like framework of NHS England. And one of the studies from 2021 showed that the nurses spend approximately 25% of their working day managing documentation-related tasks. Specifically, 15% of this time goes to documenting the care and 10% of completing these tasks. We wanted to free up that time so nurses can directly spend the time to their patients. Our approach is inspired by Dr. Zano Loksin's theory, technological competency as caring and nursing. This is the foundational pillar, and Dr. Loksin mentioned that integrating tech and nursing are not just merely as a tool. This is an integral part of holistic and compassionate care. This is the heart of our project, the Venn diagram framework, encapsulating the integration of 3 critical dimensions: digital proficiency and guidelines, nursing excellence and well-being, and patient-centric digital care. This serves as our conceptual map, guiding the initiatives that they are comprehensive and aligned with best practices in nursing. More on the author. Dr. Loksin is a native from Philippines. He's a professor emeritus at one of the universities in Florida, and he's now residing in Japan. And his theory is a middle-range theory grounded as nursing as caring. It is the harmonious coexistence between tech and caring and nursing. I would expound more on his theory and some assumptions. He said that persons are caring by virtue of their humanness. Persons are whole or complete in the moment. Knowing persons is a process of nursing that allows for that continuous appreciation of persons from that moment to another moment. Tech is used to know the wholeness of the person's moment to moment, and nursing is a discipline and professional practice. This is a Mobius illustrating the Universal Technological Domain, or UTD, which is the Dynamic Nursing Process Events, which is the technological caring encounter of the nurse to the patient as she approaches the nurse to the bedside. And that is of knowing persons as caring as lived. That's according to Dr. Loksin. So it's continuous, as he said. That's the UTD diagram, Mobius. So in brief, it is the harmonious coexistence between tech and caring and nursing, and this harmonization of these concepts places the practice of nursing within the context of modern healthcare, especially we are now in the age of artificial intelligence and robotics. And that acknowledges that these concepts can coexist. Tech brings the patient closer to the nurse. Conversely, it can also increase that gap between the both of them. And when tech is used to know persons continuously in the moment, the process of nursing is lived. Throughout the project, I was able to collect data with my key stakeholders from a mixed methods approach, trying to find out the impact of digital systems within our trust on our nursing practice and the patient care. This is how I did it. I facilitated this brainstorming session with key stakeholders, our new Chief Nurse Information Officer, our benefits realization lead, project manager, nursing documentation, assistant chief nurse in research and innovation, and many nursing leaders. And participants were given this set of predefined questions, and they were able to write their answers in the sticky notes and put that into the three circles, the diagram. We have thematically analyzed this in detail. The key areas represents the digital maturity assessment. This is the baseline of our trust, what good looks like framework. American Nurses Credentialing Center, Pathway to Excellence, and the ongoing e-hospital electronic patient records program vision of UHL NHS. We go into the detail. Circle A is our conceptual framework. This represents the ideal standards and benchmarks for digital proficiency, which NHS England has already set, of achieving in terms of efficiency, safety, and quality of care. Circle B is the evaluation framework, and this sets the criteria for a positive practice environment and high standards of nursing, where nurses can thrive and deliver that care. In the context of digital documentation, this guides that ensuring that tech enhancements support nursing excellence and do not detract the time of patient-nurse relationship. Circle C is the current e-hospital state, EPR vision states of our trust. And we wanted to highlight the tools. Is it the right tools we have? Is it the right design we have of our system in our trust in enhancing that patient-centric care? The intersections of this circle has revealed key areas of synergy and opportunity. Between the circle A and B, it is the intersection that emphasizes the need for continuous digital education and training programs tailored for our nursing staffs. As one of the clinical IT facilitators in our trust, I am part of the frontline team to educate our frontline clinical staff whenever we have rollouts and upgrades in our EPR. There should be more effective training programs within our trust or the NHS as a whole. And between intersections A and C, that overlaps the digital proficiency, patient-centric care, and the role of tech tools in enhancing patient care. It's crucial that our digital documentation systems should be intuitive, efficient, user-friendly, and make sense to the frontline staff, facilitating more time to direct patient care interaction. B and C is the enhanced nursing care with technology. This includes digital practices that should seamlessly integrate in each of our nursing workflows, reducing that admin burden and enabling nurses to focus on engagement and delivery. The core of our intersection is optimized digital care, patient care, and staff excellence, where all these three circles intersect and represents the ideal state of achieving both the digital patient care optimization and staff excellence through a comprehensive digital transformation program. So our brainstorming session unveils many key strategies to realizing this vision, including adoption of advanced digital documentation systems that can promote a culture of excellence and compassionate care. There are many challenges encountered or taken note. There are prevalence of the tick box mentality, especially in our trust, because there are so many workflows. And that means there are also insufficient training of this, and there are resources are scarce to get that skills enough to train the frontline staff. These also do not fully incorporate to the ethical dimensions of nursing informatics. Participants emphasize the need for systems that support rather than complicate the workflows. Also, there are discussions revealed that there's a critical gap aligning the standards from what good looks like and the ANCC pathway to excellence. But this means that we need the ongoing call for collaboration and focus improvements between the clinical staff and the IT staff to equip our nurses with both tech proficiency and ethical grounding to deliver quality patient care. So our analysis underscores the importance of improving quality documentation, and also key implication of this from the project is the needs for a user-centric design to allow these tools, meaning the nursing staff should be with the IT team in the beginning of the design process to truly meet the needs of the workflow. Finally, our findings highlight the potential of digital documentation to support more personalized patient care by effectively utilizing patient data. Then the care can be more closely tailored to individual patient needs and preferences. So in conclusion, our Venn diagram analysis showcased how the Chief Nurse Fellows project is holistically approaching to enhance the digital documentation practices. And we've already made significant strides of understanding these complex dynamics. Our project not only aims to enhance this digital documentation, but serves as a blueprint for integrating tech in a way that is more compassionate, more efficient, and patient-focused. The project is still undergoing. I'm engaging with the broader key stakeholders to enhance the data gathering. And I encourage everyone to join us, whatever the journey is, through direct pilot projects, contributing what your insights are to these practices into your own organization or departments. Thank you so much. This is the cohort.
Are there any questions? Can you hear me? Are there any questions?
Thank you for this excellent presentation and congratulations to the project. I have a question about the abilities to influence the software. Are you cooperating with manufacturers or with the software providers? Because sometimes we are keen to provide better service, but sometimes the software is as it is. So you have impact in your project also with collaborating with the manufacturers about the software changes to bring it to your institution?
Yes. I'm one of the clinical IT facilitators in corporate nursing. So our main EPR solutions provider is Nerve Center, and we are collaboratively working with senior nursing staff and IT staff of Nerve Center. So we engage with the key stakeholders of our trust, take that scoping process, what they wanted seeing as they transition from their paper workflow onto the user interface or digital interface in iPads or computer of our EPR. So we do that on a phased manner. We have been involved in the pre-go live, go live, and post-go live sessions of every project rollout or version rollout of our EPR. That's how we do it.
Any additional questions?
I'm just wondering how does it feel to have this activity be part of your job, I'm going to say, right? Because you're bought out from your regular job. Does it feel like you're doing two jobs, or does it feel like it fits? And I know your supervisor's here, so.
She can speak freely.
I'm quite fortunate that my line managers allow me to be released once a week to do this. And it's a career growth for me as well. And as I was trying to go through the first phase of the project, I was on my learning mode as well. I was the sponge until it came to a point that, oh, now I get it. And now I know what the purposes of the Chief Nurse Fellows program. So that's what I'm doing now today, and I'm now in front of you. And this is my first time speaking, and I'm so proud to do it today.
Conference. And I must add, we are very hot in research and innovation in Leicester, so we would like for research and innovation to be embedded in everything we do in all areas.
Hi, I'm Ann-Christine Rotgaard, the chair of EMEA, and I also work in my daily life with a nursing decision support tool and with implementations a lot in clinical practice. Congratulations with your presentation and your work, because this was really high class. Good work. It was very interesting because I kept thinking about my daily life of focusing on leadership and implementation. What are your perspectives of using your model in this, with those glasses on?
Well, my perspective would be to keep on engaging. I'm on my, I would say, preliminary phase of that data gathering, and I wanted expanding more. This was initially proposed to upskill the digital proficiency of the internationally recruited staff, because I'm one myself, but I was very supported by my mentor and the whole corporate team to scale this to the broader NHS. So I'm really felt empowered to continue this and on to what comes next on my leadership journey.
Hi, that builds quite nicely into the question I'm going to ask you. Thinking about the session that we had this morning and building our clinical and nursing informatic leaders of the future, how do you plan to be able to influence the documentation guidelines and work that NHS England is doing? Obviously, because you've got some valuable lessons learnt to share with the national team.
I'm quite fortunate that I had the opportunity by our chief nurse to be recommended to shadow Natasha Phillips. She's one of our National Chief Nurse Information Program, Information Officer, and I have been given that opportunity to engage as well with the National Digital Shared Decision Making Council. So whatever I have found out of this project, I wanted taking it further to them and to local councils that is existing within NHS England.
My apologies, but that's all the time we have for questions. So I'm proud and thank you for a most excellent presentation. So I'd like now to introduce to you Dr. Catherine Taylor Pearson. She's with the American Nursing Informatics Association as well as Texas Tech University Health Science Center. And she's going to be telling us about humanizing Lean Six Sigma, enhancing patient-centered care in healthcare.
Thank you.
Thank you.
Good morning, good afternoon, everyone, and thank you to the NI 2024 committee for this wonderful opportunity. I'll be talking to you a little bit today about Lean Six Sigma, which has many different tools, and tell you a little about some of my stories and how I've been able to humanize this process. Again, I will be sharing many different stories. They're my stories. We're going to be what I really want to accomplish today is to show you this different ways of being able to evaluate all the great things that we do. As many of you here in the audience, I have many, many different hats. Probably the best hat I have, of course, is being a mom. I'm also a 25-year veteran from the United States Army, and it's such a pleasure also to continue my role to give back as an educator. As many of you are aware, we still have a continued battle to fight with the number of medication errors that are hitting many of our institutions and affecting many of our staff. And as you're well aware of, that our environment is very complicated and chaotic at times, as you can see from the miles of IV tubing. My story talks about the intertwine of two professionals, myself and Dr. David Freeman, who also has worked against the storm against medication errors. This journey also highlights my role as a heart mom and how we've been working together now to fight this. Dr. Freeman's role originated in South Africa, and he attended a medical school right outside of Johannesburg. He and his colleagues developed many different medication mannerisms to help decrease errors, as well as try to specifically look at how to minimize IV medication administration issues. His experience helped him come up with some very unique types of tags, which I will talk about more. My story as a heart mom, nurse, and informaticist, and now a Lean Six Sigma black belt, I now have been able to work through this now and be further humbled. Congenital heart disease has impacted my family, and the rest of my story, I will talk to you more about how that has impacted us, as my daughter has worked through congenital heart disease and many different procedures. The near miss that really impacted me as a mother and now as a nurse and now as an educator was when my daughter had an unplanned admission having a cardiac MRI. She subsequently had to have a dobutamine and potassium, and unfortunately, as many of you know, those are incompatible, and so we almost had a near miss during her unplanned admission. As an informaticist, this has impacted me very, very deeply, and I often use this as a model how I look at any human factor design and engineering of most of my projects. And I can't encourage that enough, that we need to look at that. As a black belt, I constantly use the DMAIC format, as you can see up here. For those of you who are aware of it, there are toll gates at each phase through the define, measure, analysis, improve, and control phase. When we're defining IV medical errors, many of us are impacted by this. The literature certainly supports this and are ranged in numbers anywhere from 13 to 84. And as far as I'm concerned, one error is too many. Again, when we continue to measure these, there's certainly also many opportunities to look at this further, and I will show you some other mannerisms that we've been doing this. But most of the time when I'm brought into a facility to assist, I'm right there at the bedside, and I work with the staff to be able to see what they're doing. As many of you know, we are very impacted by technostress and overburdening of documentation. Analyzing can be done with obviously several different tools. For those of you aware of all the DMAIC tool sets, I traditionally often use what I call FMEA, or failure methods event analysis, and it can be very helpful. For improving the situation at this particular facility, we looked at these particular IV tags that can be added on to help minimize the chance of medication errors. And I can certainly share with you more in detail how these can be used, but that sight, that visual, that the codes were very helpful. This particular solution worked very well with the staff. Again, the go-to line was very interesting to help new nurses identify what line they could go to administer administrative drugs. They also have the ability to write on the back of them, which very much helped in this situation. During the control phase too, we've done further evaluation. So many of our, especially of our first line, frontline critical care nurses felt that these type of tags would be very helpful, especially if they're covering other patients at the front line. Other things also evaluated that this would be very helpful in other rapid response situations. So in closing, and to see how we can control the future, we certainly have many, many opportunities, and I want to also inspire us to continue to look to see how we can help each other minimize medication errors. And again, we want a world with medication without harm. Thank you. So I apologize my rapid speed, but that was my goal. That was my mission. So does anyone have any questions? Yes, they are available, and I do have points of contact. I'd be happy to share that with you. I'm sorry I did not share that since we were at rapid pace.
Great. Thank you very much.
Thank you, everyone.
I was going to Pecha Kucha. So I'd now like to welcome to the stage Daniel Rodriguez, who's going to do a quick fire
presentation on the proposal for integrating and evaluating large language models into nursing education.
Thank you. I hope you all hear me well. So I'm Daniel. I'm a nurse by training, but I work in a health tech company now, so in the industry, and I'm finishing a master's in medical informatics, and my focus is on integrating large language models in nursing education. So how are we going to do this? Partnered with the Nursing School of Porto, and Professor Ernesto is here. You all heard him before. He brilliantly presented the nursing ontology, and that's the basis for the educational software that was developed in co-creation with the company I work for, which is Virtual Care. So with this educational software, what the students do is develop care plans, and the basis of the formal knowledge of nursing they use is the nursing ontology. And we aim to use particularly GPT-4's generational capabilities to generate realistic clinical scenarios. So how are we going to do that? This is an image that illustrates basically using retrieval augmented generation, RAG, in conjunction with prompt engineering techniques to get the response we want for a realistic clinical scenario. So we realized that we couldn't do it with just prompt engineering. So what we did is to create a document of hundreds of clinical scenarios created by teachers in nursing, and we provide that document. So when this model is integrated into the software, what it does is to get the name of the course. For example, let's imagine it's a course on surgery. That will be the input for the model. And then he will search on the clinical cases that he knows about surgery and get that base to generate a new clinical scenario that's structured in the way that we want. So how are we going to assess the responses? We'll be doing a Turing test. So we will get 30 cases created by the large language model and 30 cases created by nursing teachers. And also, we'll have some qualitative assessments and quantitative, but the main basis will be the Turing to see if the teachers can know the difference between a human or a machine-generated clinical scenario. So we expect that this will enrich nursing education. This is just one of the use cases we are thinking about. We want to provide some new tools to modern healthcare education, and we will compare, there aren't a lot of studies about this, but there are some, and so we will compare our results with the others using LLM, not only in nursing education, but in healthcare education in general. And so what we are thinking about next is when we have this refined, we will create a parallel large language model that will receive as input this clinical scenario and impersonate the patient so that the student can interact with it and collect data interacting with the chatbot. We're also in discussions with the palliative care team of nursing teachers. Their goal is to create a chatbot that can respond to family caregivers of palliative care patients. And one of the first steps will probably be having the master's students in nursing, which are already nurses, validate the responses of the chatbot. And I hope this influences other research teams to integrate these technologies in nursing education. Thank you. Questions? Or we don't have time for questions.
This one.
Yeah. We haven't thought about it, but I see it as a use case we can also work for. What we aim is, we don't aim to that the large language model guides the student, but instead what we're doing is that it can act as the patient and just respond how the patient would respond. And that kind of work will still need to be done by the teacher that will assess the questions and responses, or all the interaction that the student has with the chatbot. But yeah, I think that's a good use case that we can try to do with this. Thank you.
Thank you for sharing this new information. We appreciate it. Okay, now it also gives me great joy to introduce Dr. Susan Matney with Wise Owl Originals. Nursing knowledge, big data science, terminology, and modeling update. Sorry, I can't read my own handwriting. If you flip it on, and then he'll get it for you.
Flip what on?
It's on now.
Okay. So this is Pecha Kucha. When they said you have 5 minutes and you can only go with pictures, I have 20 seconds of picture. I'm going to talk about the Nursing Knowledge Big Data Summit. Started in 2013. This is this year. We engage our leaders. Mostly people from the United States are coming right now. We're getting a few international members. It started in 2013 and started with a think tank. They got a steering committee together, and we started forming work groups, and one of the work groups that I started leading was the terminology group. There was also the knowledge modeling group, and as we started working together, we realized that we overlapped greatly, and so we formed the knowledge and terminology modeling group. This is the vision for the Nursing Knowledge Big Data mission. So each one of the center analytics, leadership, practice, innovation standards, they all have different working groups. We have influence public policy. I am part of the nursing modeling and encoding working group, where we standardize our documentation. The nursing modeling group started with 6 million instances, patient instances, and ran analytics against it to start working on specific projects. This is their process. They look at the data, they get the scope. The one I'm going to talk about the most today is pain. They do an analysis, they pull in their subject matter experts, they say, are these the right words? They get everything from the data that they have retrieved. They get the concepts and values and come up with a knowledge model. And the knowledge model aligns with the nursing process. And so our goal is to use standardized documentation to encode this knowledge model. And our main focus so far when it comes to encoding has been assessment. They have modeled pain and falls and clotting, the catheter-inserted urinary tract infection, catheter-associated urinary tract infection. And when you look at these, you know as a nurse there's a lot of things that you want to know about them. And so when they started creating the knowledge model, this is the first one, and we did it as a mind map. The next one's with the knowledge modeling, and Dr. Luann Wittenberg is here. They've been doing it in UML. But I'm showing you this because it's easy to read, and you can see all the observations that are required just for pain. And so we developed a relationship with SNOMED CT and LOINC in the United States. One of our policies is that we document nursing assessments using LOINC as the question and SNOMED CT as the answer. That's kind of a challenge, and luckily now LOINC and SNOMED are coming together, and we'll have them both in the same ontology. So we created multiple assessment panels and lots of survey instruments. There's more than 10 pain survey instruments. This is actually a screenshot from the LOINC. They'll render a form for you, and so all of these that you see on the screen are actually coded. All our value sets we put in the Value Set Authority Center at the National Library of Medicine. So if you have access to that, you can go in there and you can pull the actual value sets that we've created for our models. And you can see there's nonverbal pain indicators. Some things are hard, like associated findings. So we created heuristics. We have heuristics on how to map assessments, and we have heuristics on how do you request things from LOINC so that we can say we want a new scale, and this is the process that we go to get that done. Our next focus is outcomes and interventions, and we really want to be involved with as many people that work on outcomes and interventions for terminology standardization. And that is why I'm here, because I think that having international influence will really help us a lot. And so that was it in 5 minutes.
Right, I'd like to thank all of our amazing speakers today. It's been a really, really interesting session, and I will be catching up with some of you to pick some brains. I'd like to thank the audience for being here and having some great questions. It's now lunchtime, and thank you very much for your participation. I signed up to do a session as well this afternoon. So.